Thank you again. Again, I will not use this opportunity to show something really crazy, end of the line or very difficult. You've seen such case already this morning, but rather to convey my philosophy, which I have been adhering to throughout my interventional life. Also, again, of course, influenced by Andreas Asgrunzig, who always told me, use what is necessary, but really only what is necessary. So I have stripped down my approach quite considerably about 25 years ago, and since I've had a very frugal and simple approach for all my cases. For instance, I never use two wires, I never use kissing balloon. I have in the literature, you'll find the first kissing balloon publication is mine, but I've given up completely using kissing coronary balloon angioplasty. I do all my cases with a 5 French system without sheath. I do them mostly femoral, but you can also use this radial. It's the smallest radial approach you can use, just a wire. Then you put a 5 French left Amplats. Medtronic, as we heard before, is the softer ones. I only use Medtronic launcher. Left Amplats 2 catheter for ladies, men, large, small. It fits in about 90 to 95% of cases. You rarely have to exchange catheters. You can do a diagnostic study of both arteries of grafts, if there are any, except for the memory, which you cannot get selectively with the left Amplats catheter. You can do ventriculography with it. So everything, even in acute case, you do the diagnostic study and the therapy of both vessels with the same one catheter, no sheath. So it's the smallest entry you can have. If you use a sheath, you all know that you add 2 French to your size. If you're working so-called with a 6 French sheath, of course you're 8 French, because the outside of the 6 French sheath is 8. If you're using a 5 French catheter, no sheath, you're actually working with 5 French. So you don't need any closure devices. Actually, to put in a closure device, you would have to increase the hole by 2 French, because the smallest closure devices are so-called 5 French, but they are sheathed 5 French size, so they're actually 7 French. So this is what I've done for 20 years, and you can really finish even fairly complex cases, maybe the most really ridiculously complex cases, like the ones where you use rotablator, which actually you can also use through a 5 French catheter, not only the smallest burrs. But except for those, you can really do all the cases. And this is just one of these cases that I'd like to show you here on this panel here. Not quite sure. Here it says the mouse. Yeah, okay. You can see that first of all, this is a 73-year-old man with severe angina. It's the usual thing. If I know that I'm going to do angioplasty, I usually initially put in this AL2. I don't put in any diagnostic set, but in this particular case, I did use a 4 French diagnostic catheter set with a sheath. You cannot use 4 French without the sheath, because then your puncture site will bleed throughout the case. Why is that? If you do not dilate your vessel entry enough, and 4 French catheter without the sheath is just not enough, then if the blood pressure is higher than 80 systolically, which it usually is, with every systole you will get a little jet along your catheter entry, and you will get bleeding throughout the case. So that's of course not acceptable. 6 French will close your entry hole up to about the pressure of 160, which is usually below, above for what you're working in. 5 French without the sheath also sometimes gives you oozing during the case, because if the pressure goes up higher than 130, usually with every systole you get a little bit of blood exiting alongside the catheter, because the artery is just not enough dilated at the entry site to automatically close this hole. But so 4 French catheters, you need a sheath. That would be too small to work without the sheath. So it's usually an Infinity Cordis 4 French catheter, which is the only diagnostic catheter I've used for over 20 years. I've never used a 5 French diagnostic catheter for over 20 years. I've never used a 6 French guiding catheter. if with two exceptions, in thousands of cases for 20 years. So you can work with very small material, very simple approach. And this is just one of these cases here. You can see what was used here to dilate a rather complex situation with some lesions in the right coronary artery, with an occluded circumflex artery, with a marginal branch with lesions, and with several proximal LAD lesions. Just this left Amplatz 2 catheter, launcher guiding catheter, Medtronic, no sheath. One Magnum wire is still a wire. It's also about 25 years old. I still use it quite a lot. It's a very good overall wire. And I had to use a second wire in this case because I could not cross the chronic occlusion. So there was a choice PT wire. I use one Maverick balloon. It's cut off here, but I think it's a 2.5. And I've used a number of stents, 3 biometric stents put in the various locations here to finally, this is the left, the 4 French catheter in the left ventricle. I stopped using the machine for injecting. I used hand injection for a while. Now we've completely converted to assist, but I use like 8 millimeters of mercury, what you inject by assist into the left coronary artery, or even 6, what you inject into the right coronary artery for ventriculogram. If you are distal enough, as you can see here, you can even with about 5 to 8 milliliters of dye, you can get a left ventriculogram that gives you all the information you want. So this was a normal left ventricle. And here is the result, the final result. You can see that this was balloon angioplasty only done here. This is the stent distally, and the main stent balloon was then used to dilate this. I didn't think that was necessary to stent this short lesion. And you can see there is a stent in the former occluded circumflex, a stent in the marginal branch, and a stent in the LAD. And this is now a step-by-step depiction of okay, I'm sorry that doesn't show up here. Let's see if we can come back. No, doesn't show up. All right. Okay. So, but anyhow, you just have to believe me. What was first done was trying to get into the occluded circumflex, but it didn't work with the Magnum wire. So I just put the Magnum wire in the. Maybe I'll come back and show it on this picture here. So I just used. I couldn't get into the occluded. Difficult to manage this thing. Okay, into the occluded stump here with my Magnum wire. So I just used it for this marginal branch here. And then I used a choice PT to cross this occlusion, and so I put the stent into the branch. I put a stent into the occluded circumflex, and this doesn't show up. So let's go see. Hopefully something shows up. Well, that's not really good. Okay. Okay, all the pictures have disappeared. All right. Now, what can we do? Maybe if you come off the presentation mode, then the pictures will probably show up. They show up on that screen there. I'm pretty sure. Can you come off the presentation mode, please? Well, if not, I mean, you probably get the gist of it. Well, they also have disappeared here. Okay, so it must be. Okay. Well, is this from my Mac? I mean, the picture were just there before. Well, or anyhow, I think you get the idea. What you've seen the start and the end of it, and so, but just the sequence that was done. Because I could not cross the circ with the occluded circ with the Magnum wire. As I said, I first used the Magnum wire for the marginal branch. Then I crossed the occlusion with a choice PT, which is a better wire for all chronic occlusions. and I stented that. Then I turned over to the right to the LAD, which was also stented, and then turned over to the right coronary artery, still using the same AL2. You can just flip back and forth. And of course, what you had seen in the initial picture here was that there were good collaterals from the right to the circumflex, and at the end, doing the right at the end gave me the chance to make sure that the collaterals to the circumflex had disappeared before I was doing the right. Now, this can all be done, as you know, from femoral or from radial, and it can be done as an outpatient procedure because it doesn't need any overnight stay. And what we usually do is an exercise test, not the same day, but the next day before the patient goes home, if he does stay overnight. And this particular patient did have his exercise test the next day and was fine, and at least for 2 years has had no recurrence. I'm sorry about losing the pictures here, but thank you for your attention.